Thanks for then accommodating me. As you can see the slides, really, I profusely apologize that one cannot be there in person. And really, I do hope to make up for this. And thanks to the organizers. And then, of course, I still want to repeat that all of you are welcome to Numerai. Steve has been there, and then he can tell you really, we really need to work together on this. So as you can see, and following on an excellent lecture on how the vendor is given. So it is important then how do we complement and then how do we make sure that oncologists and neurologists can actually treat patients better, not to overtreat, not to undertreat, and of course, where possible, also where can nuclear medicine start. So in this regard, of course, the known FDG PET-CT, just the sugar that we really are imaging is established, but it's also important that we speak on FAPI as well, that is actually making a difference on bladder patients and other cancers, and so is Nectin-4 that really can actually help us to solve the problems of bladder cancers. Then, not in details, I'll just speak about then after we have imaged, we also have some options that we can do for therapy. Now, with regards to FDG PET-CT in itself, really there's a brilliant review article in the Seminars of Nuclear Medicine that I'll direct you to. It is given by a friend of mine, Kirsten, and clearly it states there we shouldn't, as nuclear physician, overreach ourselves and think that FDG is going to solve the T-staging. The T-staging, as you can see here, it doesn't work well. Can see that because of the manner in which the FDG is excreted, it will always be there in the bladder. Or you can see the defect and you can't report with confidence that this is cancer. Whilst on a CT, perhaps you will see it better. So perhaps maybe by implication, but I'll come to it to say, how can we solve it to be much better? But this is what is happening. And then, of course, where we play a role, it will be for recurrence, and then, of course, regional and distant metastasis that we do well. And then I'll come back to this example about that distant metastasis. But how then, when we request the scan as oncologists and neurologists, how we can try and make FDG work better, perhaps maybe in the form, insist that maybe us as nuclear physicians do the post-LASIK scan as well. And that tend to be better, giving the patients the fluid and then giving them the LASIKs and thereafter scanning. At least that seems to actually help with the localization. And perhaps if we modify the FDG PET scan to be standard for bladder cancer in this fashion, then that can actually help. But of course, not ideal, but I think this will be much better. And maybe that's what we should do. That example of that I've shown earlier, you can see that this patient was actually imaged, and then of course we could have missed the urinary bladder, but importantly, it detected an uptake in the cecum. And this uptake, honestly, was it from the bladder or not? And often, of course, I've seen in the MDT that listen to in the morning, it can be confusing, but at least we will direct you where you can biopsy the area without getting the areas that perhaps on CT they might not be clear where the area of high metabolism is. That direction of the biopsy, of course, led to the confirmation that it was, of course, a adenocarcinoma of the colon. So in that way, we are able to detect two cancers, which again, in the MDT, I've noticed it is rather common that we see two pathologies, and this is where it is going to be helpful in that regard, of course, including other regional uptakes. In this example, the FDG demonstrates clearly, initially the patient referred for a renal mass to which nephrectomy was done, but then thereafter, the patient was queried to be having a bladder cancer. And with that bladder cancer, unfortunately, as you can see, that problem of the urinary bladder being there, and that's why we should request the diuretic scanning, persisted and nothing could be seen, but it could demonstrate, of course, the distant metastasis and regional metastasis that I'm speaking about, the nodal metastasis, lung metastasis, and bone metastasis. And perhaps this is the strength of then deciding, are you still gonna, your plan of management, how is it gonna unfold and how do you modify it? not necessarily great work, but some of the work that, because of the numbers and perhaps the study details of the work, but however, the point that one wants to underscore here is that FDG PET-CT nonetheless, it's still good with distant metastasis, and then of course it does alter, because clearly it will then show you the areas that are not seen, and in that way, a third, up until a third of the patient can actually be helped in that way, and perhaps then James will then give over to Devin to treat and not himself if there is obviously a metastasis. And the other thing that when the chemos are being given for monitoring of the cycles, this might be another indication of which, if we have seen the lesions in the beginning. But now the issue is what is the guidelines and what more value will we add additional to the CT? Are we going to use FDG PET-CT to follow up this patient? But if it wasn't there and if it wasn't requested, that might be a problem. But then the other way around it, it might be that instead of having two requests, except for the LASIK scanning that I've mentioned, perhaps it might be good that we start requesting diagnostic CT with PET, with FDG. So you've got the best of both. So you've got your CT that would have requested, and then of course the PET CT, and then that way it can then be used to monitor the patients and look at the response, because then the CT might do the trick in that way. So now stepping out of the FDG, looking at FAPI, as we know, FAPI is really available in the country, and maybe some of the colleagues are not utilizing it. Fibroblast activated protein, it goes to the cancer-associated fibroblast. Of course, that is speaking to not direct cancer cells, but it's speaking to the soil, to the seed, to the stroma of the cancer. And then that is another way of looking at cancer hallmarks, because then if we are able to image, obviously, the surroundings, which are not so much susceptible to change, to heterogeneity and the mutations, that might also be a good way to sort of start getting ready with imaging with this. But of course, having said that, fibroblasts are also taken up by healing mechanism, degeneration and wound healing. Just like you would know that FDG does also detect infection and inflammation, the same with FAPI. However, the intensity would be something that is important, as well as the history and the MDT that can make the FAPI to be specific, of course. But bearing in mind, one of the other indications that's going to be good is things like arthritis, by the way. It does monitor it well when there is disease-modifying drugs that are being given in this particular instance. So, of course, it is not confined to the urinary bladder cancer, but to various cancers, sarcoma being one of its strengths, that it can actually be good. And then, of course, FAPI, the advantage now compared to FDG. Remember, FDG is not a theranostic type of a pair. With FAPI, which I'll show you an example at the end, you can of course see it and treat it, and that's where the interest would come. So together with chemo, when the chemo is disorganizing the seed, then the soil can be disorganized via FAPI, provided there was uptake. So we were part of the study with the German colleagues that looked at FAPI and FDG and in bladder cancer. And we can see that in this particular instance, although one has said that FDG's strength is to show regional and distant metastasis, but FAPI still outweighs actually, especially in abdominal lesions. It will outweigh FDG, and the intensity as well. It's something that makes the comfort of reporting a little bit better. So bear in mind then what one is saying, that if colleagues have requested FDG PET scanning and it was equivocal, and maybe CT it's not helping, FAPI could be requested. And as we work together with the nuclear medicine research infrastructure on some of the patients, we could try and actually, of course, see if we've got a project that we can help the patients under the auspices of a protocol that we're doing studies on. So now this is an example of how in a regional notes, FAPI will be again slightly having an edge over FDG. And of course, it's something, if you are really uncertain about perhaps the radiation area that might be needed, and as to whether there is any effort to operate, that's another example of what we can do with the FAPI. Now, getting out of FAPI, going to Nectin-4. Nectin-4, it's really an interesting one. I mean, this is highly expressed in various cancers, but and then of course, I'm glad that it was just discussed now that in infliximab vedotin, as you know, it is your cells that actually come with these drugs, and then we as nuclear physician, we can repurpose those drugs as it is in this case, to see how we can image them, and then of course use the payload to be different, to be a radioisotope in this particular instance, and then it's expressed as it is 90%, and that being the case, we can then image with it and demonstrate the correlation of the poor outcomes that might be there. If it takes, it's probably not a good thing, suppose, because the prognosis might be bad. And this study demonstrate the Simon, I don't know if he's there, but I mean, clearly when they stain, it correlates to the uptake very, very well as to what is happening. And we could try and do the study with our cohorts here of trying to stain these patients and see where we should actually engage Nectin-4 better in this particular instance. We looked at it, and then of course, in our department, we can see clearly that it has demonstrate high SUV in the primary and also reasonable SUV in the skeletal, visceral, and nodal disease. Everything is above 15, which gives a good indication that should we have a patient that might not be treated, then if it's above 15, then we can actually treat this patient. And that's really another option that we should have in the back of our mind that can happen. The examples of such, we started with FDG. You can see FDG PET scan was done for a bladder cancer of this patient, and it doesn't demonstrate that well. You are not so certain on the coronal, you're not even sure, on the sagittal, not so sure, but it's well outlined with Nectin-4. So, of course, there will be some excretion as well, but really it seems to be really correlating well with Nectin-4 compared to FDG. And then again, if you look at this nodal uptake on another patient, you can see clearly that you really have faint uptake. That might be more or less like the background. So your diagnostic confidence might be doubtful here. And then when you go to Nectin-4 with those SUVs that are high, you can see clearly that it's really good. And at least it gives the comfort of giving you a good report in that way. Similarly, in some of the small bone lesions, you can see clearly that FDG, honestly, you will report it with difficulties unless there was morphological imaging that would help you, but it becomes a bit better with Nectin-4. So Nectin, therefore, it's a good one. And then stepping out of Nectin, just showing one example of the anti-EGFR that we can do an infusion by the catheter and using a radioisotope such as bismuth. It's the daughter of actinium that we're using for actinium PSMA, but it's a short acting and it's got a half-life of 46 minutes. Infuse it and let it stay a little bit in the blood, of course, with a catheter. And you can actually treat without, that's another skill that I'm just mentioning. It's a passing by that, we have to try and exploit if we can not have some of the other drugs that I might not be aware of, and that you really are certain that it's working well, and see if we can label them, and then we can actually infuse them, and the payload being a bismuth that can help. And of course, I've mentioned about FAPI that you see it and treat it, but FAPI is done well. And of course, as one has said, it's the stroma, is the surrounding that it disorganizes, and that can go two ways. Sometimes one has to be honest, because as you disorganize the soil, of course, by apoptosis as well, the cancer cells might obviously shrink and die, but similarly, you might actually just open up the soil and then the cancer cells can really thrive as well. And this is a debate we are having, that is it going to be straightforward? So with FAPI, it is actually best that when we do the FAPI therapies, it's with the chemos. It might be that, of course, maybe the chemo is reduced or modified a bit, but then a combination of FAPI and the chemo would be a good. Treating with FAPI only, it's why I'm underscoring it. I don't think it will be a good one. It will be a treatment as a combo, but it's something that shows really there are good results that can happen. And then to conclude, Chair, one is saying that indeed FDG PET CT is there, it's readily available. It will help to hopefully avoid the over and under treatment. But of course, in the T staging, there might be issues. It's more for the recurrences and distant metastasis. With the T staging, if needed, with the contrasted CTs and then the diuretic scanning, it might help. And then, of course, we can fuse with the MR. If there is an MR somewhere, the ordinary PET CT, there are good softwares that we can actually fuse, because there's no probable need that we should get a PET MR. We can just fuse the MR and the GPET and see if that improves. And clearly, we should watch out for Nectin-4 and FAPI. Thank you. You always invite us. We should invite you to the Cape meeting, Chair, in January. Just diagnostic. There will be various things discussed, including we've got a session on ADC and other novel tracers that will be there.
Thanks, Mike. It looks like a good place to go to for this weekend. But it's usually raining. Oh, no, it's in January, so it's fine.
Yes.
Cool.
Yes.
Mike, you're online, right? Questions for Mike or any other members who did the presentation? They're all here. So I think we got maybe time for a question or two. Anyone? Sure, Dillian. Oh, Mike, a question from the audience. They just want to know which therapies of the stuff you've listed is available to us for commercial use.
Devin, you know that even in the morning in the MDT, I'm not so strong on the commercial use and so on. For me, it's to come. If you can't have a solution, I will treat it there, Numera. But for commercial, FAPI will be coming. FAPI will be coming soon. Okay. Nectin a little bit later. Yeah.
Hey, Mike, great talk. Shinga here again. Yeah. Just tell me, I didn't quite understand. You said, why is FAPI, when you target, not work as well as, like, for example, CXCR4 or the Nectin? Why do you still need to do chemo with FAPI if you're doing theranostics?
Thanks, Brashing. But with FAPI, remember that we're actually targeting the soil itself. It's the surrounding, it's the fibroblast, the cancer-associated fibroblast. So the cancer cells still remain. So in that way, for instance, I will give FAPI, then open up the cancer, open up the space, because then you disorganize the stomach. Then when you give chemo, then it might penetrate better in that way. Then you have a synergistic effect, disorganizing the cancer-associated fibroblast and then chemo targeting the cancer cells themselves. So radiation in itself, as it's supposed to be by the bystander effect, it may kill the cancer cells, but that might not be enough. And the heterogeneity that is there, it might be better that then as you disorganize the stroma, chemo is there, then that makes the chemo potentially to also reduce the dose, because then it's easier for it to operate within a space that is disorganized.
Very similar in mechanisms to ADCs. Okay, so your monoclonal antibody takes it there, and then it releases the chemotherapy, and then you'll have the surrounding cells also being affected. Okay, so it's very similar.